in reference to training. From the work that was done, it was clearly noticed that it's not a matter of the number of years we have spent in the service, but rather the number of trainings that you have gone through in relation to emergency response that indicates or that show up in your confidence level. So our recommendation was that then we should scale up the training so that at least those who will get it, when it comes to its implementation or its usage on the field, they can implement it with ease. But not necessarily looking at the number of years that the person has spent over there. That will inform the person's ability or show that the person can perform response or be capable of responding to a medical situation. But rather, if they have training, it shows up that when they come, they can respond to that. Thank you.
Number 4.
Thank you for the opportunity. My name is Hegal Jonyakon, Neonatal Nurse Faculty, Tamale Training Site. Please, I have a few concerns about Dr. Ajojenfi, her presentation concerning EBF. How can mothers who are willing to do it, but I'm sure most of in our training or in our practice, we've experienced mothers who have little or no breast milk at a point. So mothers who want to continue with EBF, but they can't produce breast milk, what happens to them? Will they rely on breast milk bank? I stand to be corrected. I heard we have a breast milk bank in Accra or in Ghana. And then in our online presentations too, with Dr. Bagbio, I think the presentation was on neonatal blood transfusion. So the complications, infections. So as I thought of the breast milk bank, will these neonates be, will they be at risk or be safe with being supplied from breast milk, being supplied with breast milk from the breast milk bank? Thank you.
Thank you.
Okay. Thank you. We appreciate that there might be some few women who may, for one reason or the other, have challenges with the production of adequate amount of human milk. But I'm also thinking through, do we really sometimes get adequate time for our mothers? Do we really have the opportunity to engage extensively with them during their period of gestation as midwives, so that we are able to educate them adequately, and then we psych them up? And how often do we even make proactive attempts to want to help them even latch their infant onto their breast in a correct way? So that if the woman just makes an attempt to start and it's not coming, she says, for me, it's not coming. So those are things that we should be asking, and those are engagement that we should be having. Then in the unlikely event that really a mother may be having a genuine concern of not being able to produce adequate amount of human milk, we appreciate that there are human milk banks. But we should know that these human milk banks that we have, they do not have the milk that is in its fresh state. They might have been pasteurized because they have to be kept for long periods. So we are aware of situations where we have surrogate mothers or mothers people who may volunteer to breastfeed other people's infants. Some are formal, some are informal. They are there. So those are areas that are less explored. That as you are in this program and you are at this conference, and if you are interested in collaborating, in researching in those areas, we can tap onto these low-hanging fruits. And then next conference, we could be sharing what we have found. Thank you.
Thank you very much. The 5th person, number 5.
Yeah, thank you for the opportunity. Solomon Ochre, pediatric nurse. Yeah, my question goes to, I think the second or the first presenter. We were worried about why maybe pharmacists and co were having about 40% as compared to maybe hospitals 49%. But the policy says that maybe the services, especially when it comes to sexual reproductive health, the services must be closer to the population so that they can easily have access to it. So I want to know why were you skeptical about why pharmacists are having that 40%, because maybe the services are now becoming closer to them, but they are not utilizing it. So now that the service is closer, then why are they not utilizing it, but rather having those issues with them? So I don't know. Maybe we can have an issue with that. And then to the other one, Dr. Ajwa, I want to find out whether you had a challenge with the support to maybe breastfeeding, the support person, where there were some challenges. Because where I work, if you leave this to the support person, they may end up rather worsening the case. So I want to know the challenges that you face in that. And then to my faculty chair, yes, I also share in the first question that came to you. Some people, sometimes they may have the money, but they look at the challenges that maybe they are facing. They may say that they won't continue again in the care of the child. So what are you also going to do? Because I also have a passionate in what helping these children, because some people may think that, oh, they can afford, but they look at what they are going to, or maybe some traditionally, maybe they have gone to see something, and somebody has told them that the child may not survive. So why continue with that? Thank you.
Oh, thank you so much, my brother, for that wonderful question. So I'm worried because, when you go to the pharmacy, yes, you come, you buy, you go home. But when you come to the hospital, we take your vitals, counsel you before we give you the commodity. That is why I'm worried. That is why we need to get the system or the services closer to them. And I want to do more into it. Thank you so much.
Thank you very much for the question. I think you wanted to find out what we'll do with those who have the money but have some misconceptions about the outcome and therefore would not want to support. I think that brings it back to us as healthcare providers. If we do our work well in educating patients, and they shouldn't come to that point, because yes, we are doing our best. We may have some misconceptions about the care, but then if we get to know what it is that is informing their decision, then we can educate them. And if you recall, one of the recommendations was to move beyond just requiring families to be present, but then to also find ways to support them. And in supporting them, we would have to find out what their concerns are and then guide them with the right information about the condition of their children. Thank you.
Yes, so thank you for the question about wanting to understand what limitations were encountered so far as the participants citing somebody to be their support person during the postpartum period. What I did share with us from the protocol was we had an opportunity of doing a first phase where we found out what the challenges were. And because we had already done that kind of homework, it gave us an opportunity through that same first phase where they were mentioning about what support they want. So that based on that knowledge, during the training phase, we were able to bring those into play. So it's limited that occurrence, so that any mother who was recruited for the third phase, that's the intervention phase, had themselves during their third trimester of pregnancy, that's the 36 weeks to 40 weeks when they were recruited, to really identify for themselves. It wasn't the health worker who nominated. They themselves identify somebody who was going to serve as a support person. But one thing that I can recollect was after we had trained the public health nurses and then the volunteers, for one of the communities, one of the volunteers opted out at the 11th hour. So we had to retrain a new person. So I think that as researchers, these are some of the things that we should also open ourselves up for. Thank you so much.
Thank all of you. Are there other questions? Oh, okay. We still have hands. 1, 2, 3, 4. We are actually enjoying the scientific session. All right. We have some 10 minutes and our time will be up. We are supposed to close at 1. That's why I'm entertaining them. Please let your questions be brief and straight to the point. Please, number 1. I gave 2 here. 3, 4, 5. Oh, you were 2. Okay. So 2, 3, 4, 5, 6. Hey, please be brief.
Okay, thank you very much. My question is to Dr. Adwoa, not necessarily a question, but I wanted to find out her sample size. Which percentage were corporate women and which percentage had their own businesses and could breastfeed throughout? I'm asking this because we are looking at taking this to the policy, extent of policy, where you want to ask for 6 months breastfeeding period. These are some of the questions that may come up. What percentage have their own businesses, and what percentage are working for someone and needs to go back at the 3 months? Thank you.
Thank you so much. Yes. So, as I shared with you, I didn't focus on corporate women. I worked more with our women from our communities who were mainly in the farming communities. Thank you.
Number 2.
Thank you very much for this opportunity.
Please, let's reduce noise. We can take it as a further study, yes, and then do that. We are in a scientific session, so you can write it down and you can look at that. Please, yeah, number 2.
I want to, it's not a question per se. I want to make a recommendation, share a recommendation, to Dr. Adwoa's presentation. We celebrated Breastfeeding Week, and then these issues came, but our focus was on nurses and midwives, because the current generation are all in their reproductive age and going on maternity leave. So I think during the forum, some 2 recommendations came up which could be implemented in a short term at the facility level. And the recommendations were that we should establish breastfeeding, counseling, rooms or areas within the facility to address the challenges that some of them have concerning exclusive breastfeeding. And also establishing daycare within the health facility where mothers, nurses and midwives, and even it scaled up because other cadres came in and said we're not the only people. And so it should be broadened. So where health care workers can bring their babies along to work, have them, being taken care of, and then go to breastfeed as and when the need arises. So I'm thinking that maybe going forward, these recommendations may be useful to other.
Thank you. Facilities. Number 3.
Thank you very much. I have a contribution to Mrs. Amakwe. Especially, you mentioned that you want to do a longitudinal study with this same research. I just want to ask, the 11% that have gone unaccounted for, in terms of your sample size, the 11% that have gone unaccounted for, I really wish you would trace them because they can really disturb you and even increase maternal mortality. You mentioned septic abortion, and I bet you it's not only the hospital or the pharmacies. These adolescents do lots of things, right from inserting things to drinking concoctions, going to the herbalist. And those ones can come in with bad cases, and at the end, your objective may be a mirage. So I really want you, going forward, especially with your longitudinal studies, to find out where these unaccounted people go to And I bet you'll be surprised the kind of things they do. Thank you very much.
Thank you. This is a recommendation. Well taken. Number 4.
Good afternoon. Thank you for the opportunity. Post to Sister Mavis. Some time ago, I heard that the family planning services have been added to the National Health Insurance Scheme. I don't know whether you were able to inform the adolescents about that development. And if you weren't able, I will plead with you to go back and then educate them more on that. I think this is very important because it will help alleviate their anxiety with regarding the cost. It was mentioned as one of the barriers. That is why I'm raising that up. So I'll plead with her to actually work on that for me. Thank you very much.
Thank you. The recommendation well taken. Number 5.
My question goes to Mr. Asafueje. I wanted to find out what preparation have you made or are we making for those at the primary health level, especially the compound and the health centers, as far as the emergency management or support is concerned? And how equipped are they going to be with resources to enable them also give the emergency care? Thank you.
Thank you, Aja. As part of our dissemination, we had engagement with the directorate, and as such, we have proposed to them a sort of training through which they can engage their primary health givers so that together we can also change the narratives. Moreover, we are also engaging other NGOs to help us, because if we want to rely basically on the central government, then it means we are not going to change anything down there. So we are seeking for their logistic support. Some have bought into this idea. So I hope that the next time when we are here, probably we'll be reporting on some of the successes that we have chopped in relation to our intervention. So that's what we are doing. Thank you.
The last person.
So I'm Oye, pediatric nurse, and my question is a recommendation to Auntie Sauda. Okay, so I share in the same sentiment in your slide that if you don't have money, you will die. And I think the NHIS came to help those who are financially challenged, especially in the rural areas. But then we've realized that sometimes you go through the whole process, and then when it gets to the pharmacy end, you are given a lot of prescriptions to go and buy outside because the pharmacy stores they don't have some. So I want to know if there can be a policy with the NHIS and the health facilities so that there can always be a stock of medication to prevent these stuff. Thank you.
This is beyond Sauda. And I believe that those of you here we have the director of nursing, I've seen her here, Ghana Health Service, and then other influential people who can help the system. Thank you very much. I give them just a minute per person to give the final comments.
All right, thank you very much, Professor Chair. I think you have billed me from Oye's question, but I just want to say something small, that what we can also do as nurses working with physicians who prescribe is to be familiar with what is covered by the NHIS, because sometimes we just recommend brands that are not covered by insurance. So if you are there and you know the options, you can advocate that with this brand we can get it using the health insurance, and then possibly the patient would get that when they go. And then for those who have influence in the facilities, you can also advocate for restocking of the medications that are mostly used by the kind of clients that come to your facility. For my last word, I just want to thank everyone for being a wonderful audience to listen to what we have to share. Thank you.
Yes. And indeed, you've been a wonderful audience. But then I would like you to take this home. Human milk is a personalized medicine. Therefore, let's put in all that we can as health workers to encourage our women who opt to practice exclusive breastfeeding to do so, working with our various stakeholders, inclusive of their partners, the Ebusiapenyi, the imams, the asofo, and all the people that count. Thank you.
Thank you so much. So I want to thank Daddy Holy Spirit and then my pastor and also my husband for helping me. I want to also thank Ghana College. I was telling my colleagues that this is my first time of presenting an abstract. So it is college who has actually built me up this way. And I'm going to graduate tomorrow. So college, thank you so much. We are very grateful. My colleagues, you are the best. Thank you.
Okay, thank you very much for your audience and opportunity. I want to say that as healthcare professionals, we play a key role in the successful implementation of electronic health records. Our acceptance of the system will go a long way to determine its success. Thank you very much.
Thank you all for giving us the audience. What I want to put across is that let's all get ourselves involved in primary health care. When you pass through your village, the next time, check through the chip compound there, the clinic there, and ask yourself, what can I do to help? Because that's the first place of call when anything should happen to your people back there. I'm grateful to my principal and my co-authors. This work has been published and treat you all to check, and if there are any support in terms of logistics or any ideas that you want to give to us, we are ready to pick it to make the change. Thank you and God bless you.
All right, thank you, our presenters. Please, you can take your seats. Dr. Ajimai Yabua, he wants to take a beautiful picture whilst I conclude this session. I also want to say that you have been very supportive. You have supported and you have made my chairship a very easy one. Thank you. You have really shown that we are in a scientific session. You were so involved, so attentive, and you asked and made the necessary contributions. Thank you very much. My next thing to them is that those who have not published, they should take the tips from Professor J. Ampon on the things to do to publish in a high impact journal, so that next time we will see their names in print. You know, I took that part. When you see your name in print, you become so happy. So, thank you very much for this period, and I hope that next time we will also see you here, as the college has done for all of us. Thank you, and God bless you.
Let's give it up for them. Let's give it up for them. Let's give it up. Thank you so much. All right. Gradually, we are coming to the end of the first scientific section. And as everybody has said, it's been an interactive, educative, and a successful first half of the day. We have some few announcements, and there is a free screening ongoing outside. We have free blood pressure checking, abdominopelvic scan, and hepatitis screening. Free. So please take the opportunity. Yes. And there is also cervical cancer screening. Outside is 450 Ghana cedis, and because of the conference, there is a package. It's going for 250 Ghana cedis. So please take the opportunity. And then there is a found bracelet and a missing owner. Please see me for some few announcements from the food committee. Please, let's take cognizance of this announcement. Meal times, breakfast is between 7 a.m. to 8 a.m. Lunch 1 p.m. to 2 p.m. Dinner is 5:30 p.m. to 7:30 p.m. 7 points. All tables or 7 points are clearly labeled. Kindly proceed to your assigned table. You may join other tables only when it is less busy. So tables labeling. We have fellows and members table. We have GCNM staff and media. We have residents table. And then we have table for the GCNM leaders and college staff. Please, in case of any issues, if you face any challenges regarding meals, please speak to any AGM COC member. Please do not engage in any arguments, right, or confrontation. Please speak to an AGM member to resolve the issue for us. So please, I think lunch time is due, but the next session starts exactly 2:15 p.m. That's the second scientific section. So please, let's do well to go to lunch and report here 2:15 exactly. Thank you very much and enjoy your meals.